guest of honor, Dr. Amy Khor, this morning. Right, once again, a very good morning, ladies and gentlemen, and on behalf of Tsao Foundation, I would like to extend a very warm welcome to our guest of honor, Dr. Amy Khor, our keynote speaker, Professor Tara Cortes, our panelists, and to each and every one of you present here today. We really appreciate that you taking time off your very busy schedules to be with us this morning, and we hope that you will find the program lined up to be fruitful and engaging. So to start the ball rolling, may I invite Kim Choo, our Chief Executive Officer of Tsao Foundation, to give her welcome address. Kim Choo.
Senior Minister of State, Dr. Amy Khor, Professor Tara Cortes, Executive Director, Hartford Institute for Geriatric Nursing, distinguished panelists for today's symposium, Dr. Marian Tsao, Chairman Tsao Foundation, and all our friends, colleagues, and esteemed guests. A very good morning to all of you. We are very honored by your presence today, and we are especially grateful to Dr. Khor and to Professor Cortes for accepting our request to share their insights with us on the subject of community nursing. It looks like a practice that has finally found its place in the sun, so to speak, as the number of older persons in our population continues to rise, and with it the demand for healthcare. From 25 years ago, when the foundation was inaugurated, we had set our sight on enabling aging in place. To us, it seems natural. Most of us live in the community, in our own homes, and as we age, that remains where we want to be. For some of us, at some time, institutional living may become necessary, but it's seldom our first choice for a living arrangement. Given that most of us prefer and do age in the community, community-based healthcare is an imperative. What we have also found is that health is not just a biomedical construct, but really an interplay of biopsychosocial factors. When an elder's social circumstances are not supportive of his health, he will invariably need more health care, have more repeated hospital stays, and a higher chance of an early landing in a nursing home. To avert this, community healthcare at Tsao is very much an interdisciplinary, team-based care management practice. Currently, the foundation has 7 healthcare services at our Hua Mei Center for Successful Aging, located at Tiong Bahru, and 3 at Comsa at the Whampoa Center. We provide ambulatory to end-of-life care across 3 different settings of clinic, center, and home. The largest group of healthcare professionals we have are actually nurses. In our health service models, the community nurse is an integral member of an interdisciplinary team. Working in a very fluid and often complex environment of the home and community, the nurse plays a very critical role in health monitoring, educating and advocating for and on behalf of the elder and his family within the healthcare teams, as well as within the healthcare system. She's also the interpreter and implementer of care for elder, explaining complex medical conditions and management, as she's often the friend and the confidant of her clients. And so our community nurses needs to be versatile, flexible, creative, able to think on her feet, and capable of applying critical and systems thinking in assessment and care plan implementation, in addition to being the ace communicator, working with multiple stakeholders. A pretty tall order, actually. And perhaps at this point I could tell a story. I remember many years ago, I was working with Yoke Hiong, Sr Fong to many of you, in the home care team. And one day we saw her, like for a couple of days, she was bringing bricks back into the office. Then we were thinking, why is she stealing bricks from the construction site? And it turns out that she was taking this bricks so that we can raise the bed of the one of the elders, whom we are seeing. And at that time, there was very little resources, so she did that. I mean, that's creativity, right? So in 2012, we developed the first aggregated community-based gerontological nursing course in Singapore. reflecting within its curriculum the multiple skills and knowledge that we would want of a super nurse. The curriculum development and training for this super nurse continues to be a challenge, but we do need more nurses for different community settings and better targeted training for their roles in a rapidly aging Singapore. Hence, we are very pleased to be able to invite Professor Cortes, who has an illustrious career in nursing education, to share her expertise with us in 2 symposiums, today on the practice of community nursing and tomorrow on the leadership role of community nurses. We are also very grateful for Dr. Cole's participation today. In the latest policy directive, the Ministry of Health is bringing health, social care, as well as psycho-emotional health by way of counseling for older persons under its wing. For the Foundation, which has long advocated for interdisciplinary biopsychosocial elder care in the community, this change could not come too soon. Indeed, it is an exciting time for community gerontological nursing, with health and psychosocial care directed towards a common vision of enabling aging in place. We have a very accomplished panel of healthcare professionals today to delve further into the subject, and we appreciate their taking time to be here for us. I wish you an invigorating morning at today's symposium, and again, thank you for your presence. Thank you.
All right, thank you for that, Kim Choo. Now, next, I would like to invite our guest of honor, Dr. Amy Khor, Senior Minister of State, to deliver her opening address for this symposium. Dr. Khor, please.
Dr. Marianne Tsao, Chairman of Tsao Foundation, Ms. Peh Kim Choo, Chief Executive Officer and Director, Hua Mei Center for Successful Aging, Professor Tara Cortes, Executive Director of the Hartford Institute for Geriatric Nursing. Ladies and gentlemen, first of all, very good morning to one and all. I think we must all be very glad that we are all dry and comfortable here. It's raining very heavily outside. It is my pleasure to join you here this morning at the symposium, Nursing Care for Community Dwelling Elders, a Professional's Toolkit. The world's population is rapidly aging. I think we all know that. We are reminded of that constantly. Globally, the number of seniors aged 60 and above is expected to more than double, from 960 million in 2017 to 2.1 billion in 2050. Singapore, of course, is no exception. By 2030, 1 in 4 Singaporeans will be aged 65 years and above, and our average life expectancy of about 83 years now looks set to increase in the coming years. With an aging population, our overall demand for health and social care will inevitably increase. And this is a challenge we must address together as a society. With a slowing labor force growth and growing demands for aged care, we will need to transform care for our seniors in a sustainable way. As Kim Choo has said earlier, most Singaporeans prefer to age at home in familiar environment. Nurses, being the core of the healthcare workforce, are central to this vision. Community nurses, in particular, work closely with families, neighbors, volunteers, and other healthcare professionals. In doing so, they anchor care in the community to better meet the needs of the population and ensure that our seniors are well cared for. Today, the role of community nurses is primarily being performed by the many nurses working tirelessly in community care organizations such as the Tsao Foundation. And I see many of you here today, dedicated nurses. Under its Hua Mei Center for Successful Aging and Community for Successful Aging, the Tsao Foundation provides integrated medical, social, and psycho-emotional care to our seniors who wish to continue living in the community. In this ecosystem, the community nurse functions as an integral member of a multidisciplinary team, working in collaboration with other health services to provide holistic, person-centered care. Let me give one example. One of the foundation's services, the Hua Mei Elder Person-Centered Integrated Comprehensive Care, or EPIC. Actually, trying to remember this is very good test of the memory. But it's a nice name, EPIC. It is a day health program dedicated to serving seniors who have multiple chronic conditions and limited social support, and who would otherwise require nursing home care. At 96 years old, Mr. Lee K.S. was first referred to the EPIC team last year. And I think many of you might have encountered, such a patient. In addition to being frail and wheelchair bound with multiple chronic conditions, community nurses Ms. Chua Ya Li and Shen Hui Bing observed that Mr. Lee had difficulties adjusting to the center as he was easily agitated in new environments. But they took it upon themselves to go beyond just tending to the medical needs of Mr. Lee to ensure that he could participate in activities like group drumming, which was popular among the seniors but will be risky for him without the nurses at hand. I'm happy to hear that Mr. Lee's chronic conditions are better managed now through the dedicated and strong efforts of the community nurses under the EPIC team. He's also happier and looks forward to celebrating his 100th birthday at the center. How wonderful. For many seniors like Mr. Lee, community nurses can play a big role in fulfilling their aspirations of living well within the community. This is why we have taken up the Future Nursing Career Review Committees, or FNCRC recommendations, to strengthen our community nursing workforce and invest in training efforts to raise community nursing capabilities. These efforts would not be possible without close collaborations between the sector and the training providers and training institutions. I'm encouraged to see the Tsao Foundation's Hua Mei Training Academy and Ngee Ann Polytechnic coming together to jointly develop the Specialist Diploma in Community Gerontology Nursing last year to equip our nurses with the skills in care planning for seniors with complex social and functional needs. Such collaboration in strengthening community nursing can go a long way to nurture our future community nurses with relevant skills. At the same time, it is important for training efforts to be recognized by the healthcare industry. In line with the FNCRC recommendations, we will be developing a competency framework for community nursing that outlines the skills and competencies needed for current and emerging community nursing roles. Employers and training providers may then refer to this framework to design flexible learning pathways. A strong community nursing workforce requires not just excellent nurses, but also excellent nursing leaders. This is why we introduced the Community Nursing Scholarship last year, which supports future community nursing leaders in furthering their education either locally or abroad. Thus far, 4 scholarship recipients were awarded last year, and they are now undertaking their nursing degree program at NUS. The selection process for this year's scholarship cycle is ongoing and will end this month. You have approximately about a week or less than a week. We welcome anyone who is interested to pursue a rewarding and meaningful career in community nursing to take up this opportunity. So that's why I say you have approximately or close to a week or less than that. But you can, if you are interested, please go apply. But if you miss it, it's okay. We'll have it again. Nurses play an important bridging role to ensure smooth transitions of frail and complex patients between hospital and home. The regional health systems, or our RHSs, are piloting geographically based community nursing teams to complement existing community care providers in delivering integrated care across care settings. The intent is for each RHSs or RHS to have a network of community nursing teams that hosts a portfolio of patients within each region. Supported by trained staff and the volunteers, community nurses will provide patients with preventive health support, such as screening and falls risk assessment. They will also help to keep a closer eye on the management of patients with known chronic conditions and facilitate smooth transitions of the patients from hospital to home. This includes providing treatment such as the outpatient parenteral antimicrobial therapy, or OPAT, in the community to patients who require antibiotic injections. For patients requiring end-of-life care, community nurses help to monitor their conditions closely so as to support doctors' decision-making and serve as a source of timely advice and support for caregivers. In the last 10 months since the pilot started, it has helped to identify and provide support to seniors who may have otherwise fallen through the cracks. For example, with the support of the Community Network for Seniors Initiative, or CNS, volunteers from Brahm Center recently brought an elderly lady living alone to the attention of community nurse Eunice Lim from the National Healthcare Group. The resident had been experiencing lower leg pain for years, but had not received any treatment due to a reluctance to seek medical care. And again, I think we have many seniors who have high tolerance, high pain tolerance, right? And who refuse, or who are actually very wary about seeking medical care. To avoid distressing the resident, Eunice and the team first screened and assessed the resident for risk of falls. Having determined that the resident was at high risk of falls, they then contacted her nephew and explained her condition to him. They also provided assurance that he had the continual support of the community nursing team as he watched over her during the weekend to ensure her safety as well as her well-being at home. Eunice and the team then made subsequent visits to monitor her condition while convincing her of the importance of timely treatment. Eunice was not deterred by the slow progress of conversations and was careful to pay close attention to the concerns of the residents. So community nurses, in addition to all the attributes that has been already articulated, patience is also a virtue and a needed attribute. Through her persistence, patience, and tact, Eunice gradually built rapport and trust with the resident, who finally agreed to have a condition reviewed by a doctor. Further assessments at the clinic revealed that the resident also had dense cataract that clouded her vision. By then, the team had built up sufficient rapport with her to be involved in her care plan, and she actually agreed to the recommendation to see a specialist for assessment, accompanied by the volunteers. I'm again happy to share that she's now pain-free and is awaiting a date for her cataract surgery. Through the collaborative efforts and proactive care planning involving our community nurses, doctors, family members, as well as volunteers, the resident is now able to continue living at home comfortably and safely while getting her health concerns looked into. Beyond having good clinical acumen and judgment, as well as having the heart and passion for their work, community nurses need to be able to practice independently, think on their feet, be resourceful in non-clinical settings, such as the new environment of a patient's home, and communicate effectively with seniors. We will continue to look into how we can better resource community nursing. With a high demand for nurses to meet growing healthcare needs of Singapore, we will also need to explore how we can use technology and innovation to be productive in our community nursing care model. And indeed, that is also one way to support our community nurses so that they are able to perform more effectively. At the heart of every transformation of care model is its people. It is only with the concerted efforts of the community care sector, communities and healthcare partners that we can succeed in enabling our seniors to live and age well at home and in the community. The shift from hospital to home will not happen without continued efforts to strengthen community nursing. Sustained collaborations across the community care sector, as well as a relentless process of learning from each other. And of course, today's conference is one of these initiatives for us to continue to learn from each other. Indeed, I wish you a most fruitful morning and a successful conference. Thank you very much.
Thank you, Dr. Khor. At this juncture, I would like to introduce our keynote speaker, Professor Tara Cortes. Professor Cortes is recognized for her distinguished career spanning executive leadership, nursing education, research, and practice. She is currently the Executive Director of the Hartford Institute for Geriatric Nursing and a professor in geriatric nursing at the New York University College of Nursing. Professor Cortes has provided significant contributions to advance the health of people, particularly those with limited access to the healthcare system. Importantly, she has developed multidisciplinary programs to provide age-appropriate care to enhance the health and well-being of our older adults across the health continuum. And now, without further ado, I invite you to put our hands together to welcome Professor Cortes.
Thank you so much, Jasmine. And thank you, Dr. Khor, Ms. Kim Choo, Dr. Tsao, and the Tsao Foundation for having me here today to share with you some of the experiences we have had in the United States in developing community-based care and really pushing it from being hospital-centric to being person-centric. So without further ado, I will move here. And the objectives for today are to discuss some of the demographics that have changed the delivery of healthcare, and Dr. Khor did touch upon this. Talk about how some of the new models of care are influencing the practice of nursing, and describe some of the models being used in the United States to enhance healthy aging in the community. Yes, aging is a global issue, as we just heard. Developed countries around the globe are aging rapidly. In the United States, 16% of the US population is 65 or older, and by 2030, that number will be 20%. Japan is the oldest country. 26.7% of their population is 65 or over. Most all of the European and Scandinavian countries are around 20% of their population. That includes Italy, France, Germany, Finland, Sweden. Singapore's demographics are moving into that direction very, very rapidly. In 2017, 13% of the Singaporeans are 65 or older. 2018, this year, the number of people 65 or older equals the number of people that you have 15 or younger. And in 2030, the number of older people will be 27% of your population, while the number of younger people will decrease to less than 11%. So the impact of this on healthcare, on economics, on the operation and function of the country becomes a very, very important issue. Challenges of aging are many, and these, I think, are universal. Some of what I will discuss today is very specific to the US, but some of this is very universal, and I think this is. Typically, older people are sicker with higher acuities and more comorbidities. Hospitalizations have longer lengths of stay. We can't just take an older person and send them home when they can't walk, when they're not mobile. Older adults often lose both cognitive and physical function during hospitalization. And this is a piece that always bothers me. When older people go into the hospital for a day, 2 days, 3 days, they went in independent, and they come out unable to walk. They have to use a cane or a walker. And there's just no reason for that to happen, so we have to keep them mobile. Older adults are more susceptible to what we call never events, such as urinary tract infections, falls, aspiration pneumonia. And older adults are often on many different medications, so changes on medication regimens often result in delirium and cognitive decline. And if you look at all of those 5 factors, you can see where nursing has an important role to play in any one of these. We in the United States had, it's not quite as fragmented now, but we have had a very fragmented care system. And you'll hear me talk throughout this presentation about the 3 C's: coordination, collaboration, and communication. We have had very fragmented settings with very little communication as the person enters a new setting. So hospital to home, home to nursing home, communication has been a factor. We've had fragmented providers, primary care providers, specialists, emergency and urgent care providers, very poor coordination amongst healthcare team members. We've had fragmented funding systems, which breaks down coordination because people have different streams of getting funded for their health care. So there's not coordination between the streams. So these were the things that we needed to address very quickly in the United States if we were going to have a healthy aging population. Our healthcare continuum today looks very much like this. People see their primary care doctor on occasion. They go to the emergency room, then they go to the hospital, long-term care, back to the hospital, back to long-term care, back to the emergency room, back to long-term care, back to the hospital, and then they die. So this is a problem. This kind of care is a problem, and this is where we need to go, where we have a healthcare system that is continuous, coordinated. People see their primary care provider regularly. If they move into a hospital, they have their acute care taken care of and then move to, as you call it here, a community hospital perhaps for rehabilitation, and back home. And then they have community care that keeps them safe at home with appropriate care at the right time in the right place. And I think that community care we need to focus on because that is providing the right care in the right place at the right time and keeping them at home and aging in place. So primary care certainly is a part of that, and I know you have some very wonderful programs here of primary care in the home. I saw one yesterday on a home visit. And then finally, end-of-life care. And that becomes at home, end-of-life care at home. So health and aging, what we need to do to really have successful health and aging is we need new models of care that are focused on building communities that are age-friendly and support aging in place. Older adults require unique health care. You cannot give health care to an 80-year-old as you do to a 40 or 50-year-old. And that is something that we just don't understand enough. We think of, oh, we learn adult nursing. We learn adult care. That takes care of everybody. It doesn't. An older person is not like a 40 or 50-year-old. They are different because they have so many complex things going on, plus all the experience of aging. There are simply not enough healthcare providers to manage chronic disease, prevent physical or cognitive decline, or encourage behaviors that enhance healthy aging unless we do that as a team. So this is why team care is so important, because one profession on its own cannot manage all of this. And it requires everyone to be working to their full scope of practice so that we have a team approach to care. The workforce was educated to cure a disease, not prevent it. That has to change. The workforce was educated to develop and drive the plan of care independent of the uniqueness of the individual and their environment. The workforce was educated to be hospital-centric, negating the influence of anything else related to health and wellness. Never before, Franklin D. Roosevelt, one of our former presidents, never before have we had so much to do and so little time to do it. The aging crisis is upon us. We need to move quickly. This is the paradigm shift that we need, from cure to prevent. Instead of research only on disease and curing, we need research on health and keeping people at their highest level of wellness. Instead of physicians and nurses' education is focused on diagnosis and treatment, physician and nurse education needs to be on prevention of disease and management of those chronic diseases. Instead of being hospital-centric, we need to be community-centric. Instead of a medical model, it needs to be an interprofessional model led by all professionals when the time is appropriate. There's a time where the physician is the leader, a time when the nurse is the leader, a time when the social worker is the leader. Everybody has a place in that team and an equal voice at the table. And instead of being physician-driven, the patient and family need to drive their care. They need to decide what it is for them that makes sense. And in the past, it was always us deciding what was best for them. Patients and families need to be involved in decision-making. So how will we get there? Well, I come back to these 3 C's. Coordination, consistent oversight and appropriate utilization of resources to provide the seamless movement of people along that continuum of healthcare, which I showed before. Collaboration, healthcare is a team sport, with every health provider, as well as the patient and the family, having a role in the health outcome. And communication, consistent transfer of vital information is essential to quality outcomes. And I think here in Singapore, from what I have seen, you have a very good exchange through IT of information across the healthcare systems. That doesn't exist everywhere else in every other country, so that you're very lucky to have that. The simple idea that is transforming healthcare is that the focus is on the person, the focus is on the quality of life, and that helps providers see the big picture and make for healthier, happier patients. So here you see the whole healthcare team, which involves the patient's family, the person's family, even their pet, in supporting the quality of life that people need. So what are our opportunities? The opportunities, particularly we're focused here on nursing, is really this practice in all settings and cover the continuum of care. So nurses to really provide, to be that link in services to help patients succeed in community-based living, is that they focus on health promotion, disease prevention, coordination of care across the system, collaboration, communication with all of the practitioners, all of the healthcare providers, as well as the patient and family. Dr. Khor referred to the nurse as being the linchpin of communication, and certainly end-of-life care. We'll talk a little bit more about end-of-life care as we move through here. So what really is driving this change? Well, we all are concerned about quality of care. But when it comes down to the bottom line, cost of care is really what is driving this change. People 65 and over have a higher incidence of chronic disease. In the United States, our gross domestic product, almost 20% of it is consumed by healthcare. So this becomes an issue for all countries because healthcare can be so costly for chronic diseases. So the impact of chronic disease on healthcare is very, very large. We find that the more chronic disease people have, if they've got 3, 4 chronic diseases, they're costing 80% of the healthcare cost is going toward those people who have multiple chronic diseases. It cannot be sustained by countries for the large number of people that are aging with chronic conditions. So we have to prevent and manage chronic conditions and keep people out of hospitals and safe in the community. And I maintain that chronic disease management, I talk about geriatrics and the older, the third stage of life, but we cannot forget chronic disease prevention from birth on. It begins at birth. So we need to also be thinking about how we are going to develop our future populations to be healthy aging populations. This is the pyramid of healthcare cost. You can see at the bottom, the biggest cost is for hospital ICUs. And then we go to regular hospital standardized care, skilled nursing facilities, assisted living, and finally, aging in place at home is the least expensive approach to health care. So that is why we need to think on how we make that happen. So this is how the United States has moved forward to move away from that fragmented system I talked about to more of a cohesive system. And this came about with what we call the Affordable Care Act in 2010. And it legislated health care to place a value on prevention and community-based health care. Without that, we would not have had the cohesiveness of moving our ship from being disease-centric to being health promotion, prevention-centric. And in 2011, the U.S. Surgeon General released what was called the National Prevention Plan. And this, in 2016, just 2 years ago, there was an addendum added, which was Healthy Aging in Action. And this addresses age-specific activities to keep people as healthy as possible living at home. So this is the intent of the Surgeon General's report. So the Affordable Care Act in 2010 recognized that the patient should be at the center of care. It shifted the priority of health care from episodic acute care to incentivize comprehensive care across the continuum. And it focused on chronic disease management. This slide is hard. I'll go into this more clearly, but it's the strategy from the Surgeon General's office has these 4 quadrants to it. One is the health and safe community environments, which is to create and sustain communities that promote health and wellness through prevention. Things such as safe housing, walkability, health food choices. The second aspect is clinical and community preventive services. Prevention-focused services, education and support, and assistance with chronic disease management. Empowered people, support of people in making healthy decisions. Elimination of health disparities, assuring equal access to health care and wellness promotion. This can only be accomplished with clinicians, their patients, and communities working together. And I ask you to look at those 4 areas and think about nurse-led community care, because this certainly is all about nursing. This is what nursing does. It focuses on health and safe environments. If we go back to our Nurses 4 founder, Florence Nightingale, was all about the environment. We've moved away from that. We need to come back to thinking about what is the environment. And on 2 home visits I made yesterday with the Tsao Foundation personnel, I was very aware of how important the environment is to the health of these people. Clinical and community preventive services. Nurses do that. Empowering people is part of the education and providing health literacy to people that nurses do. And elimination of health disparities, providing opportunities for people to seek and find appropriate resources for their health care. So the National Prevention Strategy is critical to the change of the United States health paradigm from one of treat and cure to one of promote and prevent. It builds on those efforts to lower the cost of care, because as you see, acute care is very expensive. Improve the quality and impact of population health. Health is much more than the absence of disease. It is physical, mental, and social well-being. And many of the strongest predictors of health fall outside of the healthcare setting. The Robert Wood Johnson Foundation and the University of Wisconsin have developed predictors of health and ranked counties according to these predictors. The National Prevention Strategy urges us to enhance, and this is important, enhance the traditional health workforce by training a non-traditional healthcare workforce, and utilize community resources and patients themselves as part of the healthcare team. What a surprise. Patients and community resources as part of the healthcare team. That is a new paradigm, a new way of thinking. That is more than just I who know everything. And in the past, it was the healthcare professionals knew everything, and they were the ones to tell you what to do. And we have to move that around and focus on the community and how the resources and the people themselves become the answer to the solution, not the problem. So healthy aging in action means facilitating collaborations across all sectors and professions. And this means bringing together the NGOs, the not-for-profits, the public organizations, the private organizations, all enterprises coming together to work on how do we have healthy aging and healthy communities. Expand evidence for strategies to promote healthy aging through research. Disseminate best practices and resources that address barriers to healthy aging. We need to disseminate our work. We need to talk about our work. We need to get the answers out there. Recognize the relevance of prevention across the lifespan. As I said before, it starts with birth. Bring together the private and public sectors to consider the impact of policies, programs, and infrastructure on healthy aging. And embrace the holistic view of healthy aging that recognizes quality of life along with prevention of disease and disability. Quality of life. And what is quality of life for you may not be quality of life for me, and that's why it's so important to keep the person involved in decision-making about what I want, not what you think is right for me. This is one of the more important slides as well that I'm going to show you today. This, I mentioned before about the Robert Wood Johnson and the University of Wisconsin coming together, and they have identified through evidence predictors of health. And we see right here that all of the predictors of health are not just on because you have a disease. Health behaviors such as tobacco use, diet and exercise, alcohol and drug use, and sexual activity account for 30% as a predictor of health. So health behaviors themselves. Clinical care, access to care and quality of care, 20% is a predictor of health. And then look at this, the social and economic factors and physical environment make up 50% of your prediction of health. It's education, employment, income, family and social support, and community safety. That's 40% of predicting health. And when you look around and you think about this, you can see where people who have lower economic status, where they don't have the family and social support that other people have very often have very much poor health outcomes. And then physical environment, air and water quality, housing and transit, all very important. So out of the Affordable Care Act, the ACA, we developed several different models of care which have proven to be more cost effective and they are all community focused. An accountable care organization, which came out of the ACA, is an organization of providers that agrees to be accountable for the cost, quality, and overall health care of a designated group of Medicare beneficiaries. And Medicare is the insurance program for people 65 and over in the United States. And basically it said those who achieve cost savings will share in those savings. Those that spend more than they receive could be at risk. So these are networks of providers. It includes hospitals, physicians, home care agencies, nursing homes, so all of them are working together to assume the care of a given number of patients. So this is one way of driving those partnerships between organizations and all assuming the risk. So if you do well, we all do well. If we do poorly, we all do poorly. The other one, which is the Independence at Home program, which is what I really saw yesterday with primary care, coordinated primary care being given in the home. Will this reduce the cost? There is nothing, I know that in the United States, Independence at Home is still a demonstration project, but if a homebound person gets sick at home, let's say they have something as simple as a urinary tract infection, the only way they can get to health care is to get in an ambulance and go to the hospital. Right there is about $500 just to go by ambulance from home to the hospital for a urinary tract infection. And then they sit in the emergency room, because our emergency rooms are very crowded, especially in the cities, and they sit there for maybe 8 hours, and they're finally seen, And they're found to have delirium because they have an infection and they've got a urinary tract infection. But now, they've been there for 8 hours, they're not safe to go home. So they're admitted to the hospital. So now you've got about a $5,000 emergency room bill, but now they're admitted to the hospital, one of those most expensive care pieces on that pyramid. So now they're in the hospital, they get out of bed, they fall, they fracture their hip, they have surgery, and they end up in a nursing home for the rest of their lives. This could have been treated by home care, a nurse coming into the home, assessing what is going on, looking at the symptoms, assessing what's going on, reporting to the physician, this is what I see, this is what's going on, and the physician making the proper prescription for the patient over the phone. Can be done. We're not there yet, but I saw an example yesterday here in Singapore where you are there with your model, your at-home model. PCMH is primary care medical homes. I know you're doing this. This is a delivery of primary care with a team of people, a nurse, a doctor, whatever else is specialist is there to facilitate the partnership between patients, providers, and family caregivers. The outcomes of PCMHs are to reduce the care, particularly reduce the cost of care, particularly the chronic disease management, by using best practices. Reduce avoidable use of the emergency room and hospital, and reduce the cost of drugs and adverse drug events. So by coordinating care with team-based approach, primary care with the whole team, with the nurse being a major player in this, particularly talking about looking at medication reconciliation and helping patients deal with and adjust to their chronic diseases. So the questions that come out of all this is, how will we reduce costs, improve outcomes, and have better health in our aging population? Can we impact the predictors of health, all those predictors I showed you before? Can we address the national prevention strategy in the United States, and who's going to do this? And you see here, this is the puzzle, and unless we put this puzzle together and make a whole of primary care, acute care, community-based care, and the patient and the family, we will continue to have poor health outcomes. It takes every piece of this to come together. And I put the patient at the center of this because I think we have to be patient-centric. But again, you have a nurse in every one of these areas. So that's where I see nursing as really leading these kinds of initiatives, because we have nurses in acute care, primary care, community care, and certainly nurses, a big piece of our nursing education is working with patients and families and understanding their behaviors. So coordinated collaborative care across the continuum, what does it mean? Well, in primary care, it means chronic disease management, optimize cognitive and physical function. And I keep stressing this, optimize cognitive and physical function. Keep patients as alert and functioning cognitively, and certainly don't let their mobility be compromised. Keep older adults out of hospitals and out of nursing homes. We don't want them there. Hospitals are not a good place for patients, for older patients. If they have to be in the hospital, that's one thing, but it is not a place you want to send them. So we need to use evidence-based practice, but I maintain to you, and I've said this to a couple people over the last few days, we have protocols that drive care for people in the hospital, people in the emergency room. When you talk about an older person, an 80-year-old or an 85-year-old, there's not a protocol that is actually true for that person because older people are so complex. So it takes experience, it takes kind of something inside of you that you say, you look at the patient and you understand. But that's why it's important to keep them in the community, because they're not protocol driven. They're older adults with complex, unique problems. So we also want to avoid never events such as falling in the hospital, falling in the emergency room, and infection. What does it mean in nursing homes and assisted livings? Again, keeping the person at their highest level of function. Provide patient, family-centered care, and allow for end-of-life decisions and care. I do have one slide here on end-of-life decisions and care, because we do need to talk about that, and that, again, is largely nurse-run. Assure coordination with the primary provider. Too often, a patient ends up in a nursing home, and there is not a continued collaboration with the primary care provider. That is where the continuity of care comes in, and that's again where that communication between the nursing staff and the physician or provider, medical provider, is so important. And I know in nursing homes, I assume it's probably the same here in Singapore, nursing homes in the United States don't have enough RN coverage in it. So we have to work with what we have. We need to promote the skills with the people that are there, but what we also need to do is try to get more nurses going into long-term care and understanding the complexity, the challenge of working with these very, very complex population of older adults. People think of nursing homes as being, it's custodial care. It is not custodial care. We need nurses in nursing homes. Home care, again, keeping the person at the highest level of function. Make sure they're mobile, make sure they are moving, make sure you're instructing the family to keep the patient mobile. Assure, again, coordination of care and communication with the primary care provider, appropriate management of chronic disease, and again, end-of-life decision-making. So end-of-life care, let's just take a moment on that. End-of-life care. In the United States, we spend more than $50 billion during the last 6 months of life because we take people and put them into the ICU. And they sit there for a week or 2 weeks or 3 weeks when they're at the end of life. We're changing this a bit. We're not there yet. Depends on where you are. In the United States, we have many, many, many different. It depends on what section of the country you are in. We're all different. Healthcare provision is different. States are different. So it takes a while to get this across every single state. But $50 billion because people want to do everything they can to keep people alive. And that is again, I say, what is the quality of life that this person has? And when is it time to say enough? So palliative care and hospice care have become premier interdisciplinary models for improving the quality of life and reducing costs at the end stages of life. Some of our nursing homes are really very, very good on promoting palliative care. The difference between, some of you may know this, but there is a difference between palliative care and hospice care. Hospice care is really meant for the end of life, usually stated as the last 6 months that you expect the patient will die within the next 6 months. No one can predict that. We have patients on hospice and we may think they're going to die in 6 months, and P.S. 2 years later, they're still alive. But it is intended for those last 6 months of life. Palliative care is called comfort care, to keep the patient as comfortable as possible. And when we look at our older patients at home or in a nursing home, basically they should all be on palliative care. Keep them as comfortable as possible at their highest level of function. But keeping them as comfortable as possible also means not shoving them off to the hospital at the first sign of an infection or the first sign of, treat them, keep them at home, keep them in the nursing home, keep them comfortable. And what we're showing now in some of our better nursing homes is that as many as 90% of the patients are dying at the nursing home and not in the hospital. And that's a big move for us. Most often patients go to the hospital though because the family wants them to go to the hospital. The staff at the nursing home will say, we can manage them here, but the family wants them to go to the hospital. So that's where we still have a lot of family education to do. And our limited resources, when we talk about the high cost of care, our limited resources make these end-of-life decisions even more critical. So we need to continually educate healthcare providers, policymakers, and lay people to maximize the potential of these approaches. We talk about, theoretically, we talk about holidays. It should be a good time for families to talk about what do you want for your end-of-life care. That's kind of hard at a holiday dinner celebration, but we do say that's when it should happen, not when you're 80, but when you're 40 or 45, that you're starting to think about these things so that your family knows what your choices are for the end of life. So the community. Let's look closely at that. So the National Prevention Strategy urges us to enhance traditional health workforce by training a non-traditional healthcare workforce and utilize the community resources and patients themselves as part of the healthcare team. Well, what does that mean? How can a non-traditional healthcare workforce meet the needs of people? Community-based organizations support participatory health and well-being. We need to use organizations that are in the community to provide social services more fully. At an individual level, people need to take greater responsibility for healthier lifestyles, and they need to be involved in decision-making regarding their care and treatment. Now that's a big task, to have them take greater responsibility for healthier lifestyles. The only way we can do that is through health literacy, teaching people about healthy behaviors. We've gone a far way in the United States on smoking cessation, but we still have young people. I think probably the biggest smoking population is our teenagers. And now these e-cigarettes that are out are a whole other threat to our population. But these are the things that we need to keep hammering to people on what are healthy behaviors. Obesity, children, obese children. I mean, our obesity rate amongst children is going down, but it's as high as 28% of our children in the United States are obese. It's just not, it doesn't make sense. So education. At the community level, organizations and government need to develop and implement ways to provide individual and community participation in and shared responsibility for developing and delivering healthcare services and initiatives. Shared responsibility. We healthcare organizations can't do it all ourselves. We need to involve the community. So the consistent themes are managing chronic disease with the patient and family, with community networks and regular primary care. And that second piece, maintaining the highest potential for cognitive and physical function. Physical exercise, promote physical exercise. Walking clubs for older adults. Talking to older adults about lifting books. You don't need to go to the gym. You can lift books. You can sit with your books next to you and lift them up, or cans, 2 cans at your side. Lift up the cans. But walking, moving, keeping mobile. Mental engagements, the social isolation is a major issue for a lot of older adults. How do we get older adults engaged? How do we provide community activities for them to bring them together for mental engagement? Rehabilitation when illness prevents activity. I mentioned before about hospitalization and loss of mobility. But if you have a person at home who lays on the sofa for 2 days because they have a flu, if they're 80 years old, it's going to be harder for them on day 3 to get up and walk around. So we need to keep them active. And then again, these community networks that provide resources for people. We need to improve access to those, to healthcare resources, and improve the quality and cultural appropriateness of services provided. You, as we, are a mixture of many different cultures. Healthcare differs, healthcare preferences differ, healthcare practices differ. We need to be sensitive to cultural appropriateness of services provided. Again, integrate disease management and prevention into those services provided. No matter what we're doing, we're always conscious, always thinking about what do we need to do for this particular individual to help them manage a chronic disease or help them promote health, increase mobility. Organize community resources to improve environmental, physical, and social well-being. Again, community activities, you've got to get the community involved. The community has to help provide those resources to keep the people involved. Negotiate cultural and linguistic barriers to help others become active participants in their own health. Now, community-based organizations, well, what are the things they do? There's a whole list here, and I'm not going to go into every one of them, but Bottom line is, some of what I saw yesterday through the Tsao Foundation is providing these kinds of community resources, such as you have an adult care clinic, adult day center. Adult day centers are wonderful opportunities for people to come together and avoid social isolation. The PACE program, which I'm not talking today so much on the PACE program, but for us, the PACE program is the Progressive Adults, Progressive All-Inclusive Care of the Elderly, the PACE program. That has as part of it an adult day center, but it also provides coordinated health care to patients. It's a wonderful model to keep people engaged and active because they can come together in a communal setting during the daytime. And while they're there, they have access to a physician, to a nurse, to a physical therapist, to a podiatrist, to whatever their health care needs are. Care transition services. We talked before, Dr. Khor talked about transitional services. Care management. How does the care manager help through that care the care transition from hospital to home or hospital to nursing home or wherever the patient's going? Education and training. How are we educating and training people, lay people? Caregiver respite, and I know you do provide caregiver respite. Caregiver burden is a huge issue as we have an aging population and we have family members taking care of them. We need to provide respite to caregivers to keep them healthy. So what are the community level barriers to healthy aging? Well, some of the social factors are economic insecurity. If people are economically insecure, it's very difficult for them to deal with health and chronic disease issues. There's a lack of valued role for older adults in some cultures, not necessarily in the Asian culture. But what the Asian culture does have, and this is new, is you do have, where you used to have everybody living together, families together, regardless intergenerational living, you now too are starting to live separately. In the United States, not only are we living separately, but children are moving, far away. So many people are left alone. Thank you so much. Thank you. Older people are being left by themselves, and that there's a lack of value by the community then for their aging population that are living amongst them and don't have a family support. Again, navigation of the fragmented clinical care, and this is where the nurse care manager becomes such an important factor in decreasing fragmentation on transitional care and movement of patients between different places. And lack of education on health behaviors. I maintain that we need to do more and more on increasing health literacy for people in the community. Physical factors, poor transit. Can they get to a bus? Do you have a walkable community? Many times people live in places that don't have sidewalks. Environmental factors, risks for falling. This is why the home visit is so important, because you go into the home and say, what are the risks for falls here? What is the risk in the bathroom? Are there handlebars for older adults? Do they have stairs to climb? I know of a patient who kept not showing up for an appointment with their primary care doctor. Finally, after 5 no-shows, a social worker went out to see what was going on with the patient. Well, the patient had COPD and lived in a 5-floor walk-up. And by the time the patient got to the bottom floor, they were unable to get themselves to the bus to get to the doctor's office, and therefore they never went. If we don't know these things, we just think the person is non-compliant and not showing up. So it is so important to understand what are the environmental factors that may be inhibiting their care. Patient engagement activation has proven to be a significant predictor of better health outcomes and lower costs. But again, I keep hammering on health literacy. They need to understand. They need to know what is a healthy behavior, and they need to participate in decision making. We need to see the world from their eyes. We need to see how they're seeing it, not how we're seeing it. We need to listen to their personal preferences, not just about treatment, but about life goals. Just as when I made the home visits yesterday, I talked with the nurses. What are the goals for this patient? And the goals were with the patient's eyes, not necessarily let's make them live as long as possible. What is the right care for that patient, and what is the goal for that patient as determined by the patient and or the patient's family? So quality, this paradigm again, quality outcomes, improved health in populations, and reduced costs for healthcare depend on communication, coordination, and collaboration amongst these partners. Again, those 3 C's. So here's what the healthcare continuum should look like in 2030 when we all have when this aging population really hits. We have that beautiful horizontal line that shows a continuum of care, but within that continuum we have coordination of care so that there's no fragmentation. We have collaboration amongst all the healthcare team, and we have communication, which involves the patient and the family. So how do we get there with nursing? Well, education, graduate education. We need to provide more, and we call them nurse practitioners, advanced practice nurses, I think maybe what you call them, to provide leadership across the continuum from acute care to home care to nursing homes. We need to prepare these nursing practitioners to assume a major role in the provision of primary care. Nurse practitioners, nurses really need to be so instrumental in primary care because they're the ones who really can see the holistic patient, not just the cure, the diagnosis and cure, but what are all the needs of the patient and how can that patient have the most successful aging. Reflect partnerships with other professional programs to build on collaboration, and reinforce healthcare as a practice without walls. And I talk a lot about the silos of particularly even primary care in the United States. I say, primary care sits within the silo of a doctor's office. And then how do you move that and say we're going to move this into a continuum of care across the community, utilizing the patient and family? Because if you teach a patient in the doctor's office on something in 5 minutes or 10 minutes, the patient walks out and does not see you again for 10 months or a year, they're going to forget everything you told them. So there needs to be consistency in the community. Undergraduate education, incorporate geriatrics into all relevant content. Reinforce the information that is vital to assure the safe movement of patients across the continuum and know how to assure communication. Teamwork and change and leading change, the nurse leading change from the bedside to the boardroom is essential. Research, we need to grow the body of evidence to assure best practice for our aging population. So evidence-based practice is important to influence policymakers. We're not going to make any change in legislation or in the government's oversight of our healthcare system unless we can provide evidence that practice is better. I say to researchers at NYU all the time, you must include in any of your research proposals to the National Institutes of Health, what is the cost effectiveness? Why should you do this? Because if you just improve quality of life but it's going to cost more, it cannot fly. So cost effectiveness needs to be built into research. And continue to grow the community of nurse scholars to answer the important issues. Partnerships, again, coordination, communication, collaboration. And Healthy Seniors Clinical Community Partnership, I'm going to just briefly touch on this. This is a grant that we are running. It's supported by the Human Resources Service Administration Bureau of Work Development, and it's a grant that I have at New York University. What we've done is we've recruited volunteers from the community in a very poor section of New York City with a very vulnerable, frail, older population. We've recruited volunteers. We've educated them on chronic disease management for asthma, dementia, congestive heart failure, and diabetes, and on healthy behaviors, including stress management, nutrition, exercise, sexuality, and oral health. And that group of volunteers, we've educated 90 of them. We have about 50 that are viable and working. And they go to senior centers and they educate peer-to-peer education in the community on any one of those classes. So over the last 18 months, we've educated 1,500 unique seniors, some of them attending multiple sessions, so the numbers attending sessions has been over 5,000 seniors. So we go back in and ask them, have you changed, we ask them 3 months later, have you changed your health behaviors? 80% of them say yes, and 75% of them say they perceive their health is better. Soft data, but at least it's giving us some idea of the impact of health literacy. So community-based organizations, though, the community needs to take this on as a new role, and they need to assume responsibility for increasing the knowledge. But we need to help them get the knowledge and help them figure out how to disseminate it in their community. So in summary, call to action. It is now. The time is now. As I said, we've got a lot to do in a little amount of time. Chronic care management has to be one of your premier pieces of your work. Care coordination, how do we coordinate care for that patient so that they move through that continuum in a systematic way with good communication? Patient-family centeredness. I've stressed that throughout this presentation. Unless we involve the patient and the family, we're losing a major member of the team. Focus on prevention and wellness. Prevent chronic disease from early on, but with your older population, prevent loss of mobility and cognitive function. Keep it going. The interprofessional care team, we cannot function alone. We only function well if each one of us on the healthcare team is functioning to the highest level of our license. So we need to do that, and we need to remember and respect each other for what each other brings to the table. No one is more important than the other. The community, bring the community in. They have to assume accountability and responsibility for healthcare. It can't just be the Ministry of Health. It can't just be the healthcare professions. People need to assume accountability for their own health. We need to have a care system that is seamless with the value for the quality of life and the highest potential for every person that we deal with, every person in our population. My contact information if anyone wants to reach out to me, and thank you very, very much.
Thank you, Professor Cortes. And now I'd like to invite Ms. Fong Yoke Hiong, our Assistant Director of Nursing at Tsao Foundation, to deliver her presentation on community gerontological nursing in Singapore. Sister Fong?
Good morning, Dr. Cole, Chief Nursing Officer Tan So Chin, Dr. Peh Kim Choo, and fellow nursing colleagues and friends from the healthcare sector. I'll just quickly set the scene for a panelist discussion that will be following this. So this is actually a common care pathway of an older person. I think in Singapore we are very familiar with that. You know, the care trajectory from acute hospital either to a community hospital for further rehab, or just go home, or actually with transitional care, and eventually the whole package of things when they settle at home. So these are actually very familiar to us. But just wanted to also highlight about the regional health system that has taken place recently in Singapore, the 3 cluster. So each of these 3 clusters have a range of services that are actually will be engaged to actually, so their care transition is actually smoother by engaging the stakeholders in the community. So for me as a nurse, I would like to actually highlight the role of the community Jurong nurse. To me, I use the acronym C-Care best. C stands for as a coach. So her role as a community Jurong nurse, she needs to be a coach, a care manager, a team members. She needs to report and record for accountability, and expert clinicians, a bridge to multiple stakeholders in the community and with the acute settings, an educator, an advocate, and also a resource consultant You know, this is very essential to be a good community gerontological nurse. And then just now, actually, Prof herself has shared the 3 C's of collaboration, coordinations, and communications to provide actually good care along the care continuum. For me, I would just like to add one more C to Prof, a core team. So not really just a team, but I think to hold the person or the team accountable for good continuum of care. So we need to be accountable for the actions we take in paving the way for our clients to actually administer the whole range of services across the healthcare system. So then the nurse is actually in a good position to do that, but the challenge is that for the community geront nurse, how will she be able to actually integrate her clients, the older person, seamlessly within the care continuum? So this, I'll set the scene for the panelist discussion that will be followed. With this, I thank you.
Okay, so thank you, Ms. Fong, for that. So the next segment now on our program for this morning is actually our panel discussion. So I'd like to invite on stage the fellow panelists. Firstly, our keynote speaker, Professor Tara Cortes. And then we have Ms. Chen Yee Chui, Chief Nurse of our National Healthcare Group Polyclinics. And we have Ms. Low Mui Lang, Executive Director of the Salvation Army Peacehaven Nursing Home. And we have Ms. Long Chey May, Deputy Director, Allied Health, Master Medical Social Worker and Head of Medical Social Services at Teng Fong General Hospital and Jurong Community Hospital. And last and definitely not the least, we have Dr. Chen Shiling, our physician at Hua Mei Clinic at Tsao Foundation. And I'll hand the stage over to you to moderate the session.
So, can you hear me right? Okay, so I'm Shiling. I'm one of the physicians in Hua Mei Clinic, in Whampoa, in Komsa itself. So, first of all, I just want to say thank you very much, Professor Tara, for the very insightful and very interesting talk. And also thank you, Sr Fong, for sharing a little bit about the Singapore context with us. So now we are very happy to actually have with us 3 very experienced people from 3 different care settings to actually share with us a little bit more about what's actually happening in Singapore. I think one of the first things that we would like to do during this panel is to find out what exactly is actually going on in Singapore now and talk a little bit about the challenges. And maybe Prof Tara can also share a little bit and give us some pointers as to how to move forward from here. So perhaps we can start off first with the Jurong Health side, from the acute hospital side, transitional care, community hospital, and maybe share a little bit with us about how we have tried to integrate care in this setting and some of the challenges that you have faced.
Such a big topic. I'll wear the hat as a social worker, heading a team of medical social workers in Jurong Health campus. So over the last 5 to 8, 9 years, I think this topic about building care in the community. And I think while MOH has been giving some directions, but I think on the ground practitioners have always been looking at how we can do care and conduct our care better. And as a medical social worker, we always have been looking at care continuum. We do know that a person is a resident before they become a patient, and then they go back to the community. So despite very often as they have a fall or whatever health episode as they come in, they have to go back to the community. Personally, at Jurong Health, for myself, I've also tried out years back developing some kind of care continuation, looking at how we can better profile a person holistically, right? So I've also, so there's this thing called health program where we talk about mobilizing allied health professionals, mobilizing them to also develop training modules to go to the community, social care people. Because as a MSW, I know that the social is very social, health is very health. So how can we make sure we better, like what Prof said, we do need to come together and develop something that is holistic, because looking at them very person-centered rather than medicalized or being social. Along the way, we also talk about developing some lifestyle, preventive work, chronic disease self-management program, stroke self-management program, tying in with stroke association, because I had the good opportunity of visiting different countries, look at the care model, and every time I go to another country, I copy shamelessly what is useful and helpful back in Jurong Health Campus, because we are also one of the new cluster before we merge with NUH, testing out certain model. And I think we are also building capability, because nursing is such a big workforce, and social workers, for your information, not many social workers in Singapore. I happen to be the president of Singapore Association of Social Workers, right now trying very hard to see how my family center, the social care, the cluster support social workers together with the medical social workers, how can we come together to work very closely with allied health and nursing in various settings. So we have this preventive work. We also have community health posts. We do know that community health posts, you have a model where nursing led, but in Jurong Health, we also mobilize some of the allied health also to see how do you do that as a model of community health posts. So I also noticed over the years there are many different programs coming up. And I think next few years we really should see which is the best one and to kind of like merge it into a model, going to a precinct to see how we can test out some of this. But mind you, I also want to remind healthcare professionals not to be so paternalistic. The community themselves know what is good for them, and each community differs. Like when we were in Alexandra Hospital, the profile of the patient is quite different from where I was from in SGH, and now that I'm in in the Jurong side, the profile really changes, despite Singapore so small. But really, and you need to really truly be person-centric, really look at what they need, then you talk about programs and intervention. So I just listed a few of the programs. I also know that there's a lot of layperson development framework that's ongoing, which I think our NUH, because now RHS planning is under cluster, so I will be spending some time in ComOps, and the next, we also want to see how we can spread, sustaining what model is good in the community. So these are some things we have done, mobilizing not just, and to work closely with the medical team. And I do appeal for, I also have this wish, to have allied health and nurses to take a bit more lead. Because when you go to the community, I think the doctors, let them do the doctoring and the specialists in the hospital. In the community, there's a chance for us to also, if we go to community, we know the person in the environment. And we can really feedback and work with doctors like yourself to, you give your expert opinion and how can we do some of those things better.
Sounds like that's a lot of things that you've been doing over the years. What are the challenges that you face actually? Because you sound like you actually work with many different organizations, many across different care continuums as well. And you were also previously from SGH and now in Jurong Health, right? So what has been the biggest challenge, let's say, that you feel?
Mindset. I think first we have to make sure we all see a role, and professionals, okay, we are professionals and professionals have code of ethics. We do have to abide by our code of ethics. So while we do that, we also need to be flexible and be more updated and relevant when we go to the community. So sometimes I see professionals guarding their profession. But we know that when you're in the community, you need to have a bit of cross-train, You're not losing your identity and all that. You just need to know a bit more. Because it's too expensive to put a whole team into the home. Your person and the patient also get confused. So many faces. So the mindset change and influencing people takes a while. But I must say, and happy to say that we have moved. Because I went to Jurong Health in 2009, now it's 20, it's been 9 years, and I see that shift. Yes? Oh, okay.
too close, yeah. Okay.
So
okay.
the mindset change and getting people to understand the community care and the social care scene for the healthcare. So I also have some reflections. So the challenges in terms of helping people understand and not to be too pushy, to take over people's care. We do have a role and we do have a space. So try to go in and understand, and sometimes, because when you're social side, you say don't come in and medicalize things, whereas so you have different, so there's some tension at some stage, but I think we have both. We collaborate, your 3 C's, we collaborate a lot more better, but I think we are not consistent in holding. And while you were talking about the baton, passing the baton, I was reflecting, it's a 4 by 100 meter, or 4 by 400 meter, or 4 by 1,000 meter. Meaning the speed and how you pass on and hold the baton is important. I know Zeno is not about holding but how fast you pass, they're willing to take or not. You break the rule of, you pass baton must be within a certain distance also, Really, people willing to take or not, or you drop the baton. I mean, I'm just thinking of that analogy, right?
Yeah, I think we should have a few batons here.
I'm passing.
Yes, okay. Maybe we go right across to something that's completely in the community. Since we've been talking about the hospital, in a community hospital, we go into the polyclinics actually, which is really primary care. It's really where a lot of our patients actually first go, our elderly patients and their families. Maybe a little bit about how care has been integrated there?
All right. In the primary care, what we are doing slightly differently recently, in recent year, is to actually organize our care for patients with chronic disease, right? We have started forming teams and empanel our patient. What it means is that before that, care can be really fragmented. Patient come and patient go. It's all episodic, right? And then we do not really have that long-term relationship with our patient. And what we realize is that without that, a lot of things cannot happen, right? So we go into this, a few of the key points, such as forming into teams, working with doctors, care managers who are registered nurse in trained in chronic disease management, care coordinator, coming together, care for a team, a group of patients, and follow them out, allowing the continuity of care, allowing also the collaboration between professionals, and of course, the next step will be working more closely with the community to take care of this group of patients, right? So that's the new frontier that we are facing, we are working on. And within the cluster, NHG, National Healthcare Group Cluster, we are also forming a community nursing team, right? So riding on to the funding from MOH, what has been reorganized are different groups of community nurses who used to work for different population under different project funding, and then coming together, organized together to actually group them together to take care of population from different geographical area, right? This is a new thing that only happened recently, and then coming together also mean that we collaboratively train and look at the training, the competency of community nurses, the career development of community nurses, to look into making it a growth area and to support the growing healthcare population needs. So these are the recent happening. Of course, challenges, there are many. One of which is, if related to how the community nursing is organized, initially by grouping people, the funding structures are all very different. We have to put them together, we have to synchronize. It's still happening, it's still work in progress. Many of the key players are here. And apart from that, from the primary care setting, it's also a new concept for everybody, including the patient too. So we are still a long way to go in including the patient in the care and focusing on patient-centered care. So these are the new development and our challenges.
Okay, so it sounds like it is trying to build capability in the primary care itself, as well as actually collaborating, right, with the tertiary hospital, as well as with the completely community partners like home medical teams and all that. So there are challenges in this entire thing. Okay, what about the nursing home setting? Yeah, that is a unique setting certainly for an elderly.
I will wear the hat not just of a nursing home, but even of the day center. So basically, over in the nursing home, what we need to understand that nurses are not just like typically like the hospital nurse doing a procedure. Actually, there's very little procedure, but there are some. And you know, a lot of time, we actually try to upgrade our staff to a level what I understand to be case managers. Okay, because we under the regional health system, formerly the EHA, Eastern Health Alliance, had this privilege of going to Philadelphia and see the Geisinger model. So when I went there, I said, yeah, this is the model that, you know, nurses should do. So, and how I pack it, I said, pack it one step below the APN. So this nurse really able to go to the NHR, find out all the answer, what this person has been going through in terms of medical, in terms of their medical, work through with the doctors, because we do have doctors on site that I bring them in so that my resident don't need to keep going to the hospital. So while they stay in the nursing home, we provide treatment, which is a bit unusual, but we provide the first line of treatment. So those with urinary tract infection should not be going to the hospital. We should be treating them. Pneumonia, we should be treating them unless it is getting a bit more difficult and doesn't work with the oral antibiotic. So this philosophy that we have been doing also carry out to the day center. So in the day center, you know, when you go to the day center, older person go to the day center, the family will say, you look after my mother, don't send my mother all over the place, just say, provide all the care, right? So this center in this day program now is called Integrated Home and Day Center. We provide the whole total care. So whether they need to go into respite care or they need long-term care, eventually we work through with the family. So those people who are living alone, as long as they are safe at home at night and can be safe in the community, they can still come to a day center. They avoid going to the nursing home on a long-term basis. So we have managed them. But one of the things that we find the challenge is, again, family lah, okay? Because, you know, normally day center, we operate Monday to Friday. So why do I operate Saturday to Sunday? So historically, my Bordeaux Day Center, Monday to Friday, Saturday, Sunday, my staff will be calling the family. Hello, how are you? Are you coping? Because where all the admission goes? Saturday, Sunday. To the A and E. You know, my staff report to me, I say, we must stop this. So what we do is, out in the community, we need good communication skill. We need to communicate with family what even to expect from this short-term illness, I would say, you know, urinary tract infection, because we give antibiotic. And we also look at how, assess the family, how are they coping. So some of the family, they really cannot cope. So we say, okay, it is all right. This Saturday, Sunday, I take you in the day center for respite, and nighttime, you still go home and be taken care of. Or if they cannot cope because the person really have delirium and get a bit more confused in their own home environment, then we bring them for short-term respite. So in order to keep them out in the community, I believe that we need to provide the whole total holistic care. But one of the difficulty is staff training, right? Because professionally, we tend to be quite boundary, and we think that's all that we can do, and we are afraid to move the frontier. You know, in 1993, when I joined Tsao Foundation as the first nurse, let me tell you, I struggled with, late Dr. Lee. He said, sure or not? Can nurses can do. Can I just call you and start treatment? You know, I didn't have the confidence, you know, with my assessment. And she said, can, sure, yes, okay, we'll do it. And you know, that is where I learned. Okay, today the doctors, you know, because as executive director, so I got opportunity to hire doctors. So then I will hire the doctors. I say, doctor, we are different type of nurse. Okay, we will call you. You have to trust us with our assessment, and we will start treatment. Can? If you can, then we will have this partnership. So we do have this partnership too with Changi General Hospital. So we also have partnership under the regional health system, under the e-care project, even the nurses coming in to help support my nurses, to educate my nurses. Because one of the difficulty, the challenges when we work in the RTC sector, hospital forget they progress, they are educated in whatever they progress. We in the RTC, we have to find our way. What have you changed? What is the latest today? You know, so unless we know of a forum or seminar, then we will know where we can upgrade ourselves so that we will not be admitting someone, we look at it, stare at it, and do not know what to do. But one good thing about the RHS system is now IRTC, we all nursing home have friends in the acute hospital, you know, and they are just one phone call away. How So I always call Lao Soy Soy, CGH. How Soy Soy, this one like that. Okay, then she will tell me, you know, what are the things that we can do and what would be within our capacity even to do. Because last year we started chronic sick unit. So you can imagine, you know, because when AIC refer, they just refer. But whether we have the capability is another story altogether. So, you know, but because CGH is my good friend and partner, that's how we learn. So I think one of the things that I would like to say is collaboration is important. You know, collaboration. Even my day center, we have to speak to CGH staff, even when they upon admission. So, you know, for Peacehaven staff, when our resident get admitted to hospital, well, I always tell the staff, please don't call during the peak hour, otherwise you become a nuisance. We always call and say, how is my resident? Okay, because we have people to visit, but they are not nurses. So we actually can pick up what is going on and what's happening from the hospital aspect, and then when they return back to us, we also know how to journey. Especially, you know, as we begin to move on the journey of palliative care, you need to do PPC, then we have to have a conversation. What family agree in the hospital? So sometimes they come back, they tell us a different story, right? So we have to pick it up. And today we are very privileged because we have the NHR, that we can always find answer, find out all the results, and then from there, but nurses must be able to interpret. Okay, look at MRI, not just read what the doctors write, but also to understand diagnosis. So their knowledge in terms of anatomy, physiology, and knowledge of the medical aspect of it also has to grow. So community nursing is very highly skilled nurses. You also have to be multitasker, social work, therapist, whatever you can call it, right? But that is what is needed, but we don't need to be, we are not alone. We can go back to the professional and say, I see this. How do I do it? And it is from there that we all have our experience developed through all this learning journey.
Okay, thank you very much. I think the take-home message is we must have many friends so that we can have people to call. Later, I get your number, okay? Yeah. I mean, to be honest, it sounds very complex. We're all mostly medical here, I think, in the healthcare setting, so I think we can sort of understand what everyone is sort of saying. But I think if it is someone who is outside of the healthcare sector, for example, like the patients that we're talking about and their families, they'll probably find it very difficult to understand all of these things that we're saying, which is really the challenge of navigation, right? Navigating all these different services, whether it's hospital, community hospital, transitional care, primary care, nursing home, and then all the under nursing daycare centers and nursing homes and all the other intermediate care facilities. So the question that I actually have is actually something to do with what Sister Fong said just now about the core team. And maybe, you know, Prof Tara can also give a bit of insight about this. This question about how there are nurses in all the different settings, right? And we talk a lot about collaboration and transitioning patients from one service to another service, from one setting to another setting. But the question is, are there some patients, or even almost all patients, who will require a core team, a primary team, to actually hold on to that patient and that family, you know, as they go through and walk through all the different settings? Because very often we know that information does get lost in between, and for particularly vulnerable patients and complex patients, they do get lost, no matter how hard we try. Yeah.
Do you want me to address the core team? Because I'm sitting here thinking about the core team, and I think probably to think of the same group of professionals following the patient throughout the continuum is probably not realistic. Too expensive, and also I think there's a specialization that goes on in terms of acute care, long-term care, primary care. However, again, we talked about the nurse as being the linchpin, and the nurse is in every one of these places, that he is the constant member of the team. So I think we need to learn how to pass the baton to the next team, and the next team takes over the care, because the team is going to look a little different. I think, I think in hospitals, I to me, and you alluded to this, that the doctor leads the team, the physician leads the team. We're there for treatment of disease, treatment and cure, or progression of disease. So the doctor, to me, is the leader in acute care. And that's why I always say, particularly in advanced practice nursing, boy, they belong out in the community. Because in the community is where I think advanced practice nurses and nurses really can shine and be very autonomous and lead practice and lead health. But again, you know, there are team members, and there are times that the social worker is an important member. There are times when the physician is an important member. So I think the passing of the baton was a perfect example of how we could visualize this. So the team passes the baton on to the next. So the core team may have the same professionals, but again, the core team always has the patient and the family. So that is always, that's the constant member, and perhaps that is why they need to be such an important part of the team, because they are the only one that really move from the hospital to the community to the long-term care facility and back around. So that probably is the core team.
Maybe I want to just add that even for the H2H program, hospital to home, you know, we have different levels and things like that. Even right now, I'm looking at when we assess the needs, needs has different, is it really expressed needs, real needs, or perceived needs, and all kinds of needs. The assessment is very crucial. And at different point in time, so you really have to follow the person's journey. If they have certain family condition where they have complex needs, and how do you define complex needs? Sometimes within a family situation, they may have some intellectually challenged person, poor social support and things like that, or they may have undergone certain, or they have certain risks. You do know that what VAA is? Huh? You know what VAA is? May I show of hand when I say VAA? Very important when you go community nursing. Vulnerable Adults Act. And when we talk about MCA, Mental Capacity Act. Now these are some things that perhaps you can then work closely with the social worker, because we have to work very closely with the Ministry of Social and Family Development. You know, you have your child protection, you have your adult protection, because they have the statutory power. Only they can do certain things. And I suppose when you look at a person in the environment, social work is about the person in the environment and very family focused. And you see that there are a bit more family dynamics and all that, then perhaps really go to the social worker to discuss, because we have to also keep ourselves updated what is happening in the legislation and some of those things. Of course, it's good for anyone to know. I mean, if you just Google, you go to the statutes online, you can read. But sometimes the interpretation and the complexity and the case discussion. So going back to the core team, it's a multidisciplinary team, right? Even in Jurong Health, we also started MDC, multidisciplinary clinic. Team discussion is quite standardized across the world. For certain profession like rehab, oncology, and certain things, you always have that multidisciplinary. So you must know as a group, decide who gives more guidance, who should be the face to the person and the family. If they are more stable, then you have to see, because it's a relationship. To me, when you attend to the person, we alluded to the thing about trust. In casework, in case management, you must have the relationship. Who are you to enter into a person's house to tell them what to do, right? They must trust you, they must understand that you are genuine in the care, right? And they trust you as a profession, and they trust that you are able to provide good, sound advice and support. So I suppose the core team is important, but at what point the needs, because our needs vary. If the crisis mode is over, if they're more stable, and where you have mobilized certain resources. And I want to remind us, sometimes they have support. It's just that they lost the support. You know how Singapore, not just in Singapore, I think now every country work very hard. Their children may be just busy, not that they don't care. But you need to mobilize them, and if you have to link them, then you can back off a little bit. Never take over the person, you know. Even the core team, sometimes the family you just back off, and when there's a crisis, teach them when to call us back when there's another crisis. So I would say the team provides that support and all that.
very good to have a social worker here, actually. Yeah, this is actually a call to action as well, that the social sector and the health sector probably really has to come together in order to provide support, for the elder as well as all the vulnerable adults in the community. So in that sense, I guess, like Prof Tara says, the core team actually is the patient and the family, right? So it is possibly to just build them to be the core team, to be able to empower them, and so for them to be able to self-advocate, right? I guess that's what you're sort of saying as well. Yeah.
As I was thinking throughout this from each one of the panelists, again, the importance, because the models are there. I listened to all of you, and the philosophy, the models, the examples are there. I think our next frontier is really population health. And how do we move the health behaviors, health itself, the big picture of health, to the person out there, so that they understand what it takes to become a healthy person, that we really hardwire into our population those behaviors, the exercise, the nutrition, the mental wellness, the whole aspect of feeling good and confident about oneself. How do we hardwire that into the population so that they also have an ownership for health, and it doesn't just become the health professional managing everybody, but management becomes a group thing that very much involves a healthy population.
Okay. Yeah. Sister, do you have anything you want to add about them?
Maybe adding to what Prof has mentioned, that the self-empowerment of the professionals like the nurse, because we're always like kind of a coach as well. So it's actually engaging the older person and the family in terms of giving information, and also teaching them how to actually navigate themselves, in terms of proficiency if they ended up in the hospital or in the clinic, and how to actually ask for information so that they know better actually how to actually decide, what sort of care they would prefer. And then in communications with the professionals, I think is very much often from a home health care nurse perspective is actually be able to actually listen carefully to what the older person and the family wants, and able to actually discuss with the goals of care, so that joining the dots across the continuum, and the message can be actually being very person-centered. What do they really want, and empower them with knowledge, so that the care coordination and the collaborations within the care continuum can be meaningful, and it makes sense to the clients. Because after all, we don't run their lives, but we have to empower them to take ownership. And also the professionals as a nurse, we are actually very close to our clients, is actually to do the extra part of the advocacy, so that we can speak the lingo of the professionals, but we can actually come down with the health literacy to actually communicate that information to our clients, to make actually informed decisions regarding their own lives. Yeah, so this is probably an urge for community nurses to have that sense of, I would say, it's a responsibility to want to do the empowerment and want to do the advocacy for the persons under your care.
I mean, we're talking a lot about different professions, multidisciplinary sort of care and all that. And I think one of the things that Professor Tara, you have mentioned quite a few times is this interprofessional model. Yeah, perhaps you can share a little bit about this? Yeah.
I think that the aspect or concept of interprofessional practice is absolutely necessary in this day and age. I've talked about the need for each professional to work to their full scope of practice. I know in the United States we have a far way to go when I look at our primary care setting. What is the role of the nurse in primary care? And primary care traditionally had been a physician practice. You go to see the physician in their practice, and I think we need to move away from that physician practice to what is the role of the interprofessional team in that. The physician doesn't have to do the patient teaching. A nurse can do the patient teaching. A social worker might do the patient teaching. I think, I think of a patient example. It was a Hispanic patient who had trouble being compliant with their medications. They always forgot to take them. And the patient was Hispanic, and religion was very much a part of this older person's life. The social worker had the idea, put the pills in front of their statue, because every morning they had a religious statue that they would pray to. Put the pills there, and sure enough, compliance increased. So it takes a village. And the village is all of the team of the professionals, because we all bring a different way of looking at that patient to the table. And unless we utilize and respect what each person brings to the table, embrace it, listen to it, and make it part of your care, and get away from the idea, only I can do this. This is my practice. I have to do this. We need to get rid of that, and we need to talk about the we. The we is the team. We together are doing this, and we together, by the way, also includes the patient and the family.
So in some way, even in the interprofessional team includes the patient and the family, right? They're part of the entire interprofession. Is this something, maybe I want to ask again, in terms of the polyclinic setting, because I think that tends to be quite physician-centric, right? Is this something that you think can happen in the polyclinic setting?
All right. Like what was mentioned, traditionally doctors, even patient, the way the language they use, I'm going to see the doctor. And that's what they have in mind. Take medicine, see doctor, right? So it's actually a long process that we're going through now to emphasize on the team, recognizing that actually there's a value of having a team, right? And that part of which actually come from the need to build relationship, and also recognizing that in chronic disease management, patient behavioral change is important, patient empowerment is important, and the person who can do that do that the best are the nurses. And at the same time, I think also recognizing that we can also engage our lay person to actually help in the team, right? So our care coordinator do come in, and then with their level of engagement, they're able to reach out to the patient, and then we find that to a certain level, they are the one actually fleshing out issues, able to actually surface, and then able to engage the patient. So as a whole, we are starting from scratch, and then it's still a long way to go, but we are recognizing that this is actually roping in value. But even in the community, we find that like community health posts, we do have lay extender as well. And they actually are the one actually able to communicate, probably auntie to auntie level, with the patient, at the same time engaging them to come to do health screening, to come to actually follow up for appointment. We do have cases that they go to the community health post, talk to them, and then not sure whether they should come to the polyclinic. And then in the end, with the encouragement of the lay extender at the community health post, they actually turn out for follow-up appointment. So we see the importance of the whole team working together here.
Mm-hmm. That's actually sort of like the non-traditional workforce and caregivers that we're talking about, right? Yeah, I think, for this physician-centric, that's very much in polyclinic. I think we don't really have to honestly worry about nursing home, because we have a very strong nurse advocate here. And I think we don't really have to worry about the hospital, because we have a very strong social work advocate here. But how about this issue about the non-traditional workforce? Is this something that is happening very much in the nursing home setting, daycare setting, as well as the hospital setting?
Okay, I think basically in terms of nursing home, I can't see how we really use this lay extender. It's just that, we have yet to, I have not yet think how we're going to how to actually utilize those volunteer workforce that we could have as lay extenders, right? But I know that in the community, in the Bedok area, in the Fishan area, we have a lot of lay extenders. We are actually, because there's a community network, for seniors. So we have a lot more things going on out there, and we are engaging volunteers. We have the befriending program, and we have many other like CREST program, commit. There's a lot more program in the community today that we are trying to navigate and see how we are going to put all the pieces together, all for the concept of looking after the older person and keeping them healthy. So I know that because we have been so curative in our thinking, today we really have to talk about prevention. And so that there will be further development in the area of prevention, even in my organization, out in the Funsan CC area in Bedok.
Okay, I have actually many more questions that I would love to ask all of you, but unfortunately, time's up. So I think one of the things that's very clear here is that, to be honest, I don't know how many in the audience are nurses. A lot of you, right? Most of you, right? Yeah. I don't know how you feel at this point in time, but I think the role of a community nurse is actually really, really extensive. You need to be a nurse, you know, as a nurse. You need to provide care, you need to coordinate care. Now you need to do therapy, you need to do social work, you need to advocate, you need to educate, you need to do preventive work and all of that. Essentially, you just need to be a super person. So whatever it is, I hope that this session here actually inspires all of us here, you know, to want to do more in the community for the patients and their families, and that many of the nurses here will be inspired to want to take on more in the community to make things better. Thank you very much.
Thank you. Thank you to the panelists. Please remain on stage. So at this juncture, as our session is about to draw to a close, we would like to extend our thanks and appreciation to our panelists as well as our guest of honor, Dr. Amy Khor. So can we now call upon Dr. Amy Khor, our guest of honor, and Kim Choo on stage to present to Dr. Amy Khor the token of appreciation. Yes, and we would like to invite Kim Choo to also present tokens of appreciation to our panelists. Ms. Chen Yee Chui, Professor Cortes, Ms. Low Mui Lang, and Ms. Long Chey May. Okay, maybe together we can take a picture together. Everyone? Oh, okay, sorry. Can we also invite Dr. Marianne Tsao? Sorry. So with this morning's session has come to a close, and on behalf of Tsao Foundation, we would like to extend our heartfelt appreciation to our guest of honor, Dr. Amy Khor, and distinguished guests, for taking time off to be with us today. Can I invite you all to stay in your seats as Dr. Amy Khor takes her leave? Thank you once again for your presence here with us today.